I'm very fond of Australia. I actually have family in Bunbury. I spent a semester at UNI's New South Wales and love Sydney. My time there many years ago, and so again, this is really an honor. And so, what I'd like to do in the next 45 minutes or so, and then have discussion, is talk about, sort of an overview of medical malpractice, and I'll be talking about the United States system. I did some brief research on Australia, and certainly there are some differences, but there are some similarities as well. But this will sort of give you an idea of what's happening here. Want to talk about specific patient safety and kind of malpractice risks in neonatology. And ultimately, the goal is to demonstrate ways to improve safety and minimize risk and better prevent malpractice lawsuits. And so I'd like to start with briefly with an overview of malpractice in the United States. The American Medical Association follows this issue quite closely, and there are kind of, concerning statistics. About half of physicians 55 or older have been sued. I'm 56. And then, as you can see in this pie graph, when you look at the outcome of the lawsuits, you can see that the majority, almost 65%, end up dropped. About a quarter are settled, which does mean that there's a payout to the injured party, and about 10% go to trial or mediation. And when cases do go to trial, the defense actually wins the vast majority of the time, probably around 90%. But in the United States system, each side pays their own defense costs. And when you talk about neonatal kind of birth injury cases, they can be very expensive because you have so many different experts, and that really adds up. You have, neonatologists and pediatricians and obstetricians and radiologists and neuroradiologists and neurologists and placental pathologists, and it really can easily cost $100,000 to defend yourself, and even more if it goes to trial. When you think about malpractice, you really, a lot of times you think about, well, it's the neurosurgeons and the obstetricians that really are affected. But in truth, pediatricians have the highest payment average of all specialties. And the defense costs are higher as well. And you can also see in the bottom left corner there that the mean payments for babies, for neonates, are more than older infants and older children combined. Um, And then finally, this graph looks at claims based on severity with respect to pediatric malpractice. And there are really two important points here. And the first one's kind of obvious, and as you might expect, an emotional injury only is going to be a lot cheaper than a permanent, major permanent injury, or significant permanent injury, or and death actually is a little less expensive because the costs are less expensive. But if you look at the yellow line, you see that the more severe the injury, the yellow line is the percent of time you have to pay to make the case go away, either through a settlement or loss at trial. And you can see that the more severe the injury, the higher the time you have to kind of pay to make it go away. And so I know these, I've thrown out a lot of statistics, and real cases generally have more impact. And so I'd like to show, a case in 2019 in Baltimore, Maryland, where a jury awarded $229 million for a 25-week preemie that had a poor neurologic outcome. And this was at that time the largest medical malpractice award in U.S. history. And so the question comes up, why are baby malpractice cases so challenging to defend? And the answer is really seen in this and get his photo. And so, babies are cute. Having a baby is supposed to be a joyous occasion. When grandma dies in the ICU, when she's 95, people understand it. People don't understand that something can go wrong with the baby. And so if there is, well, hey, I see all those miracle stories in the news, and you can save her. And so we know, of course, that while the media kind of focuses on the miracle babies, often the ending isn't so happy. And here's an example from 2006, so it's almost 20 years old. But there was a baby, 21 weeks and 6 days, and this was IVF, so it was perfect dating. And the baby survived 283 grams at birth, Amelia Taylor. And this, made the national news and made and so that was sort of what people expect when they hear about a premature baby. And again, you can understand why non-medical people have such high expectations. This is one of my favorite studies. It was published in the New England Journal of Medicine, where they just watched TV and said, how often does CPR on TV work? And it's just as again, as you've probably seen on TV, when people get CPR, they sort of cough a couple times and sit up and are fine. And so that is sort of the expectations of the public, and it's really juries who are lay people and not medical people who ultimately are the deciders in these medical malpractice cases. So, what do you need to prove when someone alleges malpractice? And I do believe this is similar in Australia, but these are not criminal cases, they're civil cases. And so the burden is not the same, first of all. So, there are four elements. And the first thing you have to show is that you had a duty. So, you're on call for, covering labor and delivery, and you get called to a delivery, you're going to have a duty, to that patient. There's going to be a physician-patient relationship. The next uh, burden is to show that there was a breach in the standard of care, so that you sort of breached that duty by not practicing to the standard of care, which we'll talk about. The next element is that the wrong that you did, the breach in the standard of care, has to cause a problem. And then finally, you have to show the plaintiff, and this is the burden is on the plaintiff to show all these. They have to show that that problem led to measurable damages. And so again, duty is usually, again, someone's on a schedule, you're covering the NICU, that you have that relationship. Really, the main battle in most medical malpractice cases is over the breach and causation. And so, what is the sort of standard of care? What is the care that you're expected to provide? And the standard is really known as kind of reasonably prudent care. So, you're supposed to act like a similar neonatologist in good standing and use the sort of similar care and diligence and judgment applying your skill to care. So you don't legally have to be perfect. You don't have to be the best neonatologist in the world. You're supposed to act as a reasonably prudent neonatologist would in similar circumstances. But one thing that's very important, and I see this all the time where people talk about standard of care, it's a legal concept, right? This is something that's applied to the specific fact patterns of the case in litigation. The plaintiff's attorneys, are going to claim that you departed from an acceptable standard of care. Your defense is going to be like, no, I met the standard of care. And as I pointed out, juries are made of people off the street who are not medical people, and they don't know what a reasonably prudent neonatologist would have done. And so expert witnesses are used to explain it to a jury. And there's a lot of variability in the United States in the quality of the expert witnesses. And I'll show you an example of what I consider to be egregious testimony. So this was from a case involving an abruption at delivery, and the baby lost a lot of blood. And the neonatal expert said, well, once they realized that the baby had lost this blood, then they immediately would have given a saline bolus and gotten blood from the blood bank. And typically in a hospital such as this, you can run to the blood bank, sign out the blood, come back, and have it available to give within 5 minutes. And again, I've worked in a number of different hospitals, and I don't know of a single hospital where I can run to the blood bank, get blood from them, and get back in 5 minutes. But a jury doesn't necessarily know how unrealistic that is. So that's sort of an overview of medical malpractice, and I'm happy to talk about it further. But now I'd like to turn and talk about more specific patient safety and malpractice risks with respect to neonatology. And so, what is kind of different about babies? We've mentioned some of them, but there's just a number of things about neonatology that increase the risk of errors and malpractice lawsuits. Number one, we can't obtain a history from our patients. Number two, some of the most frequent errors in diagnosis lead to severe and permanent injuries, such as missed meningitis, delivery room problems. The reason these cases are so expensive is that the lifetime cost of care can be staggering. And so if you have a baby with cerebral palsy who needs 24/7 care, they have a trach, that adds up to millions of dollars. As we talked about before, these babies, you can have enormous sympathy for these babies, right? They're never in any fault in any way, shape, or form. There's no often prior, physician-patient relationship. The families have to place their trust in someone unknown to them, actually multiple people. We're coming up on the holidays. There are always, um, a lot of different people who are covering during the holidays. We have long stays. We actually, in our unit, have three babies who celebrated their first birthday. Uh, these babies get multiple medications that are packaged in sort of for adults, and the dosages are individualized for each patient, and the dose for each patient changes as their weight changes. And then finally, there's a long statute of limitations. The statute of limitations is the length of time in which you have to file a lawsuit. And in Ohio, it's 20 years for newborns because they have 2 years from the day that, until from when they turn 18, which is when they become an adult. And so, you know, I know it is longer for minors in Australia as well, although I don't know exactly how long. So, anyone who took care of babies, in the last week, imagine being sued in 2035 for that care. Or alternatively, and as I'm getting older, you know, I have to think about the care that I provided in 2005. I could be handed an envelope tomorrow saying you're being sued for care you provided in 2005. And so this is one of the many reasons why proper documentation is so important because you're not going to remember what you did several years from now for a case. And so the medical record becomes the main source of information that is provided years later. And so documentation it's very important. You do want to document there, the saying goes in the medical legal world, if it wasn't documented, it wasn't done. And, that is of course not true. We can't document every single thing we do, but again, the record is going to be the most important source of information when these cases go to litigation years later. And so it is important. So you do want to document the care you provided, you want to document conversations, but you don't want to use a chart as a battleground. I told those surgeons they needed to operate and they didn't listen to me and they're idiots. Um, but you do want to document also, especially for trainees and things, you do want to document the use of the chain of command and when you contacted your superior, things like that. So now we're going to spend some time talking about real cases. All the cases I'm providing are real, and they're not done, to point fingers or to judge. They really are done because a very primary concept of patient safety is to learn from mistakes of others so they don't harm other patients. But these are some of the things that I see commonly in lawsuits and currently. Resuscitation is always important. We always need to pay attention to what's happening in the delivery room. We need to work on teamwork skills. We need to keep up to date. The neonatal resuscitation program, which guides care in the United States, comes out every 5 years. And in fact, a new edition just came out this month. And we have until June to implement those changes. So intubation, for example, is one of the most gratifying procedures in medicine, but it's also a very high risk time. And so let's look at a case. So we have a uncomplicated term pregnancy, some distress in the monitor, thick meconium, and a respiratory therapist who was present for the delivery. The baby was born blue and floppy, and the RT did not intubate or give oxygen for 6 minutes. And unfortunately did an esophageal intubation that it was not detected, and the child ended up with quadriplegic cerebral palsy. They sued both the delivery nurse and the respiratory therapist, and it was a $7.5 million settlement a few days before trial. And of course, with the advent of end-tidal, CO2 detectors, this is really not you cannot leave a tube in the wrong position, and this does happen. Intubating infants is not easy. I use it for positive pressure ventilation as well. This is from another case. You can actually see the endotracheal tube and the air from the end of the endotracheal tube going directly into the stomach, and this was another case where the tube was left that way for hours. And additionally, and I'm not going to belabor this point, but trainees and they're much less skilled at intubation than they used to be. They get way fewer attempts. Um, and it is not a breach of the standard of care to miss an intubation, but from a clinical, from a patient safety and a legal point of view, that's okay. But if the tube is in the esophagus, you have to recognize it and get it out. Jaundice is another area of high legal risk. This was a real tragic case of a baby named Kara who was born in 2014 at 38 weeks gestation, big baby, breastfeeding, and an AO setup. And the mom had had a prior baby that required phototherapy. They got a Billy at 2 hours of life that was elevated. It was 5.5. They didn't do anything about it. The nurses just sort of documented jaundice, and the baby went home at 49 hours of life with a follow-up for 10 days later. So they sent home on June 6th saying, we'll see you on the 16th. The family wasn't educated about jaundice, but they noticed that 3 days after discharge that Kara was not, she was lethargic, she could not latch, she had a shrill cry, she was increasingly yellow. And they called the clinic, who said they would see Kara on Friday the 13th, which I'm not making up. That's not a very lucky day in the United States. 2 days later, she had a shrill cry, was arching. Mom called the clinic and left a message, and a nurse called back and said, well, I'll call the clinic in the morning. And the next day, the mom called the clinic and finally gets seen, and they draw blood and send her home. And then the Billy comes back and is severely elevated at 33.4. And Kara is then brought to the hospital, and it's too late. She develops kernicterus. And you can see here from the Butani nomogram that at 2 hours of life, this was a elevated Billy, but none was done after that until 194 hours of life when it was 33 and off of this chart. And Butani's got, this is when we see kernicterus, it's not uncommon that there's a big gap between the bilirubin prior to the, catastrophically high Billy in the 30s and 40s. And so this was a $46.5 million verdict. Again, kernicterus is a very, horrible and permanent condition. It requires 24-hour care, intense medical treatment for life. And so, again, the numbers are very, very high, kind of shockingly high, but these are the cost to care for someone for their life is very high as well. And so, when we look at these cases and they say, what can we learn from this case? How do we prevent this from happening? This one, quite frankly, is a number of education lapses or, basically incompetent care. An area where I'm seeing an increasing number of cases involves sepsis. There was a few years ago, there was a jury award after a full-term baby. Looked great, APGAR's rate 9, and then on day of life 2 developed tachycardia and intermittent apnea and bradycardic episodes. Was ultimately diagnosed with E. coli sepsis and meningitis and developed cerebral palsy and delays. The lawsuit alleged delay in diagnosis, and this was a $27 million jury award. And sepsis is one of those things in the few decades I've been, it's really changed radically in how we all practice, right? When I was training, every baby in the NICU pretty much was placed on antibiotics, and that was not the right thing to do. And our approach has changed. That's a good thing. But now it is a lot more complicated determining who to start on antibiotics. And so the American Academy of Pediatrics has clinical reports, early onset sepsis above 35 weeks, less than 35 weeks. Many in the United States are using what's called the Kaiser sepsis calculator, where we place risk factors in and it lets you know what to do. And it takes into account factors such as the gestational age and the highest maternal temperature, rupture of membrane, etc. So it's just a lot more complicated now. But there also is, I do get concerned sometimes that there's too much emphasis to trainees on antibiotics are bad. Antibiotics are life-saving, and we have to understand when to give them and not when to give them. The Kaiser calculator is very specific about, if you have this heart rate for this long, you meet this category. And so I do have residents and fellows who tell me give the baby a chance and hold antibiotics when they meet criteria on the calculator. And I tell them the calculator was the chance. That's so we just do need to educate and use antibiotics appropriately because they still do save lives. Cooling for hypoxic ischemic encephalopathy is another big area. Given the criteria to cool and the high risk for poor long-term neurodevelopmental outcomes, remember babies who get cooled still have a 30 to 40% risk of a long-term problem. So I assume that every baby that gets cooled will at some point have their records reviewed by a lawyer. They're just always tragic cases. The pregnancy has gone great for 40 weeks. The labor sometimes has gone great, and then something catastrophic happens, and now you're talking to a family about brain damage. Um, Now, before cooling, malpractice focus in these areas were just on the OBs. But with cooling, there is now a reason to bring in neonatologists who can be sued because you didn't cool when it was indicated, you didn't document appropriately to show that a baby didn't need to be cooled, or you cool the baby, but you didn't get them cooled within 6 hours of age. And so going back to, one of the interesting questions was when did cooling become standard of care? The first uh, trial was published in 2005, but of course, neonatologists take a time to adapt things. In the United States, the NRP 2011 edition was the first to really recommend therapeutic hypothermia, and so that sort of to me is the latest you could not cool. The important thing about what NRP says is that not every place has to cool babies, right? It requires specialized equipment and special consultants um, to do. So not everyone has to cool, but if you work at a hospital that does not cool babies, then you have to have relationships and a low threshold to transfer a baby who may be a candidate for cooling, because if you delay that, then you may not be able to get them cooled within 6 hours. And then the late preterm baby, this is, they are known, Majbus Frank, who's a neonatal nurse practitioner in Vermont, and part of a big part of the Vermont Oxford network, calls late preterm babies the great imposters. If you look here, you'll see there's actually 3 cats and a dog. Um, you know, these babies, they look like term babies. They used to be called near term. A lot of them, we have 35 weekers and 36 weekers in our normal newborn nursery. They have, they're at risk for hypoglycemia, getting cold, respiratory distress. They can have sepsis, jaundice, apnea, poor feeding. So, they really do need to be watched, more closely while they're in the nursery and in the hospital, and have appropriate follow-up before discharge. And then the final one is kind of a broad category, but so important in modern medicine, is this idea of safety, right? We're caring for sicker and sicker patients, and providing care in a very complicated environment. And this is a typical ECMO patient, and just look at the equipment and the screens that need to be monitored. And so, we really have to pay attention to the care we're providing. And so many of these can be broken down into a number of different categories. Um, and so we'll look at a couple of examples. There was a baby born in Seattle in March 2001. Initially looked good. The allegation is that the nurse did not monitor the baby appropriately, and then she went to look at the baby. The baby was not breathing, so she called a code. It took a long time for help to arrive, and then the patient became intubated and looked good. And then the respiratory therapist grabbed the wrong ventilator tubing that did not have an exhaust valve. And so if you looked at the lawyer's website, it said the baby was then, quote, blown up like a balloon as they developed bilateral tension pneumothoraces and basically arrested. So the patient ended up with cerebral palsy and severe and permanent brain damage. It settled for 7.8 million. But the reason I'm bringing up this case almost a quarter century later, it was the response. So the newspaper in the city, the Seattle Times, actually sued to have the record unsealed. And they said documents in the court file do not explicitly identify the restorative therapist in the case. And since neither side would discuss the lawsuit, we can't find out who this restorative therapist was. And I find this very troubling. This is not how you create what's known as a culture of safety, which is so important in medicine, but especially in neonatology. And so, saying, this was sort of the traditional response, right? Well, that error was that respiratory therapist's fault, and we just fire them, and we've taken care of the problem. And we now recognize that's not true, that most errors are systems issues, and blaming a person will rarely solve the problem. But patient monitoring and handling is another area. We're humans, we make mistakes. We always got to be vigilant. There was another case of a full-term baby brought to the NICU, had mild respiratory distress. They turned around quickly and were shipped back to the normal nursery 9 minutes later. They then became apneic. They told an aide to take the baby back to the NICU who misunderstood and left the baby in the normal nursery. And the baby ended up with hypoxic brain injury and died. That lawsuit settled for $1.1 million. And, again, if you look at that case, what is it? It's a lot of different things. And, again, babies that are brought to the NICU do need to be stabilized and monitored appropriately. We also, I always see, when I decide to bring a baby from the, labor and delivery to the NICU, I made up my mind. I don't care what other people, they kind of make fun of me. If the baby looks good when I get to the NICU, some people will have kind of, the nurses will kind of glance at you. Why is this baby here? But sometimes the younger trainees, again, feel intimidated. And again, that's not the culture you want to create. Patient handling is so important. They're just, this was just a silly, error where a nurse was cutting off the ID band for a baby being discharged and ended up cutting off the tip of his pinky finger. And that actually went to trial with a $125,000 verdict. And then this was a tragic case. It was a 27-week preemie born in a community hospital that wasn't equipped to take care of 27-week babies. The nurses knew that the babies needed to be kept warm, so they heated up some saline IV bags in the microwave and placed the baby on them, and the baby developed third-degree burns as a result. And that was a $9 million settlement. We've talked also about medication errors as a major source of legal risk when caring for babies. We've discussed some of the factors, but it's also, I always bring it up because some of the greatest tragedies in neonatology and the history of neonatology have really surrounded medication errors. One occurred in 2006 in Indianapolis, where a pharmacy technician stocked the med cabinets with the wrong heparin that was 1,000 times stronger than normal. And 5 different nurses didn't check the label, just went to the cabinet and gave them to their babies. And it was a real tragedy. 3 babies died, 3 had injuries. You can see the different bottles, the vials there in the bottom, and you can see they really do look fairly similar for such a massive change in dosing. The one's 10,000 units per ml, the other is 10 units per ml. But the hospital did not, to their credit, the hospital, was very upfront and honest, and they really said, we're going to look into this and try and figure out what happened and try and prevent this from happening to others. And we're going to take care of these families and pay for the funerals and offer compensation and try and help out. Obviously the parents understandably were still angry, right? One of the moms, she was a beautiful baby. Why did Methodists have to kill my baby? Why? And the answer, of course, is very complex. There's no simple answer to why errors happen. This is Neo Review's article from 2008 that just talks about how NICUs are complex adaptive systems, and usually when an error reaches the patient, it's a series of things that have the Swiss cheese model that things have lined up. Um, Methodist Hospital made a number of changes, and they removed those vials entirely from their system. They put in validation and education, but importantly, they didn't fire anyone. And again, that was a change from the usual approach. Would have been like, okay, we fired those nurses, we have no issues anymore. And we also have to understand the toll that that errors have and malpractice suits also on physicians and nurses and all the healthcare professionals involved in the NICU when mistakes are made. They've been called the second victim. You have to it's very hard to wrap around. And how we support them is important as well. This is Kim Hyatt here, who is a pediatric intensive care nurse. She was involved in a 10 times error for a patient, and she was escorted from the hospital by security, fired, reported to the nursing board, and she committed suicide 7 months later. And so, again, how we support everyone is so important because again, the system is how we improve safety. And going back to the tragedy that happened in Indianapolis, you couldn't make it up. 2 months later, the exact same error occurred, except this time it was to the actor Dennis Quaid. And he had twins, Thomas and Zoe, and they had the exact same error in California. And now this was a celebrity, a movie star. He was on the cover of People magazine. He advocated, and now Baxter Healthcare actually changed the packaging so that you can see now there's a massive difference between the 10,000 units per ml and the 10 units per ml. There was a lawsuit involved as well. Thankfully, the twins did well, but there were some payouts as well. So the last part of the talk, I just want to sort of talk about how can we improve safety, minimize liability, and better prevent malpractice lawsuits. I wish we could just have a sign. That doesn't work. But there are things we can do. We've talked about some of them, and we'll go over them. Documentation, we've talked about importance. Keeping up to date is so important. Conferences, literature, again, NRP changes every 5 years for resuscitation. Think about, in the past, we didn't have end-tidal CO2 detectors, so it was a different standard. Now we do. Use of steroids for in neonates goes up and down. Keeping up to date is so important. I always have to mention privacy and confidentiality. It's privacy and confidentiality aren't new. They date back to before the Hippocratic Oath, but the internet and the texting and Facebooking and everything has such a major impact, and it's cost a lot of people their job. I have in my hand, this has cost a lot of people their jobs. There are always, in the news in the United States, physicians behaving badly, nurses behaving badly, posting inappropriate things. This was from a OB resident sort of group chat that went public. You just always have to be very careful. You can lose your job. Informed consent is so important. It's much more than a signature on a form. You really need to talk to families and communicate with families about what you're doing, why you're doing it, what the benefits are, what the risks are, what the alternatives are, what happens if they say no to any treatment. That's the concept of informed refusal. And if we go back, this is such a crucial area. If we go back to that $240 million verdict that I presented earlier on, that actually was reversed because the appeals court said the mother had appropriate informed consent. A C-section was recommended and she refused. And so the $240 million became $0 because of good documentation of informed consent. So communication with families is so important, and also communication within the healthcare team. This was a tragedy. This was a patient named Mackenzie Bryant who had a heart transplant as an infant, and she, um, at age 4, she had kind of a stuffy nose, and her mom was told if she's ever sick, then you need to call the cardiologist. And so she called and spoke to the fellow. The fellow said, "Let me call my attending." The attending said, "Make sure that she doesn't give Afrin, which is a nasal spray." And the resident misheard and said, "Oh, you should give Afrin." And then she arrested and was left with permanent brain damage. And so, just like you see in aviation, the idea of a repeat back policy. Don't give Afrin. You said give Afrin. No, would have avoided this error. So it really is important with communication. And then finally, and I know I've talked about it a lot, just this idea of culture. The idea of um, a safety culture where this is one of my favorite slides, right? You've got the boss and any other objection. So if you don't have a culture in your NICU where people could feel free to come to you and say, "Hey, I think this is a concern," you know, um, many times before an error reaches a patient, there have been what is called near misses. And if you can catch a near miss and fix that problem, then that's a much better kind of safety culture. The best way to avoid malpractice lawsuits in some ways is to try is to avoid the error from happening in the first place. But I do want to emphasize that safety culture is important, but so accountability still does exist. Um, I always think back to when I was training and there was a surgery resident who refused to wash their hands to come into the NICU. I mean, it was really unbelievable. And they got banned from seeing babies in the NICU because they wouldn't do it. So, accountability is important as well. And then I have some other, we do look to other industries. Aviation, is certainly one that for how they create safety cultures. In Toyota had what's called the Anden Cord, which allowed anyone on the assembly line to stop and say, "Hey, there's a quality issue here." And then I have a couple of books I always recommend. So Captain Sullenberger, who, if you remember, there was a plane that hit a flock of birds on takeoff, lost both engines, and they landed the plane in the Hudson River in New York, and everyone survived. And in that book, he talks about, no, it wasn't just me. It was the safety brief we had before. It was the simulation of landing in a river. There were a lot of different factors. It was a team effort. And I think that it's a very useful book. And then Atul Gawande, who's a surgeon and a sort of wonderful writer at Harvard, has a book, a very short book called The Checklist Manifesto that I think is important as well. And then finally, when errors happen, patients want to be informed. It really is sort of an ethical obligation. It's a legal obligation in the United States. And there have been a lot of programs now that are, um, you know, basically looking at, the University of Michigan as an example, where they'll look at, when there's a bad outcome, they'll take a look at it. And if they see that, they were at fault, they will proactively go to the family and say, this was something that we did that wasn't to our standard, and they will offer compensation up front. And again, they've found that their legal expenses, which can be quite significant, were cut in half. And again, it's just helps create that kind of safety, because errors are always going to happen, and part of it is how we respond when they do happen. And I should disclose that I am a NICU parent as well. That's my wife, Christy, who's a neonatal nurse practitioner. That's our firstborn, who is a 32-weeker, who's actually about to turn 13. And so being on the other side, you do get an appreciation for just how, how important it is that the team knows your baby, and how important all the safety issues really are. And you can see he has now been joined by a younger brother and sister, and is uh, doing well. So this has really been a pleasure to give this talk, and I look forward to discussion and any questions that you may have.
Thank you, John. That was great again. I really enjoyed this overview. Again, you started with the USA stats, how big is the problem? And you have that medical liability report, which I think is awesome, because I'm not sure if we have that in Australia, with the outcomes of what I thought was interesting, a quarter almost like dismissed or sort of put on the side. Then you talked through cases and you explained humorously as well, but very importantly, the expectations of the public, which is very different than our own expectations. And then you went to a lot of cases and explaining the process of, duty of care, breach of duty, causation, which I do have some questions about, apply to neonatology. And you ended off, how can we break this circle, which is all about safety and incident management and reporting of that and getting back to it. So thank you so much for this overview. There's no questions in the text box, but I'm going to ask Nick. Nick, do you have any questions to start off with?
So I'll unmask myself. Sorry. No questions really, more comments. And I think that, my experience would parallel Jonathan's very closely. There's obviously sort of fairly important differences in the Australian context. I mean, when it goes to trial here, there would always never be a jury. It'd always be a judge in terms of things. I mean, I think that one of the things that I feel, I mean, you mentioned the quality of some of what passes for expert opinion. And I think that that's an issue that really troubles me, because, if if they can sort of get up any sort of case, they can actually sort of run it and push a defense to the point where they're having to face the costs of a trial, and then actually sort of push the case through from that. And I'm not sure there's a way around that other than rebuttal of those opinions. But I think that that is a real issue. And one of the things that I find a constant challenge is how you communicate the influence of hindsight bias on the way that people view something. You're judging people with knowledge of an outcome that the people who are making the decisions didn't know that that was going to happen. And I think a lot of expert opinion doesn't actually address that. And I suppose fundamentally doesn't address, because certainly in Australia, we make a commitment that actually our duty is to represent an independent opinion to the court. We're not responsible to one party or the other. And I'm sad to say that I don't think all experts actually they make that commitment, but they don't follow it. And so I think that that's one of the things that worries me. The other thing is that every so often you see cases where there's a really, really important patient safety message, and I think, Jonathan, the way you're presenting this and talking about it is a very important thing. But we don't really have a mechanism to get that safety message out there. And I've certainly had cases where I've said, look, this has really important general safety things. What can we do to actually publicize it, or just disseminate it? And there's absolutely zero interest from the lawyers in doing that. And I don't actually believe the lawyers are that interested in patient safety, because clearly patient unsafety is what keeps them in money. And so that's one of the things that worries me, is that we don't really have a mechanism to actually communicate those things. In terms of the specific situations that I see, the things that I would add to the list that you have, I don't think we've yet seen so much here of suing around initiation of hypothermia. I haven't seen many of those. But what I do see more of increasingly is cases revolving around babies at the borderlines of viability, 23, 24 weekers, who you wouldn't think would be the ones that would be most sort of in there, although I suppose they're highest risk. Line accidents is the other one that I see a fair number of. So arterial line accidents, digits get lost, central lines end up in the wrong place, sometimes with absolutely disastrous outcomes. And also hypoglycemia. Hypoglycemia is the other, really difficult one. It's sort of it's a little bit like jaundice in that there's an awful lot of it around, and most of it ends well, but sometimes it ends disastrously. So those would be the things that I would add and my comments. But otherwise, I think my experience would actually be very similar to what you're describing.
Right. And I it's funny when I pick the hot topics, and I do try and change them some, but one of the ones that absolutely is that you never saw malpractice around a 24-weeker, 2 decades ago. And now it's relatively common, and it is, they're obviously at higher risk for poor outcomes. You go back in the thousands of pages of medical record, and you can always find a sugar that was too high or low, carbon dioxide that was too high or low.
Yep.
So it's, and then you kind of finger point at that. I do, it is interesting. Pediatricians, and I was chair of the American Academy of Pediatrics Committee on Medical Liability and Risk Management. There are some organizations like the neurologists, for example, where they actually, they kick someone out who they said you're giving egregious testimony, and don't call yourself a fellow. But one of the problems again is in the that they just then say, yeah, it's because they don't want you to know the truth, and I'm telling the truth.
Yeah, yeah.
It doesn't doesn't have that. But the emergency medicine group actually, what they'll do is they'll just take what they call consider egregious testimony, and just publish, put the transcript online for everyone to see. And that's another thing I thought was kind of effective.
Name and shame.
Yeah, it's basically.
Well, yeah, but getting the information out there, so that overview of what is actually happening and what's the outcome, I think is lacking in Australia as well, that we need some more sort of clarity and insight of what is actually going on. We've been warned by our employers, no, give every case you think might go to a lawyer, just highlight them, which is basically every HIE case. And some other cases, but I'm not so sure because I don't get the feedback what then actually happens with that case. About
Right.
safety though, Elizabeth Chong has a question about that. Elizabeth, you want to unmute yourself and ask the question if you're capable? Maybe not. I'll do the question for Elizabeth. It was any advice on the balance between trying to not conducting a witch hunt and improving systems to reduce errors versus ensuring that people are not calling something a system error for political correctness or actuality, a bit what you just discussed about. What advice? How can we find that balance between saying this is a system error or recognizing the true system error?
Right. And that's a very good point. Again, that's part of the reason I put the accountability slide in there as well, is that there are, take medication. We've had, nurses who will take our barcoding system, and then they'll put the sticker on their, sleeve, and then as a workaround, and then you get an error and you go, well, but I do think taking a look at, I think in some ways, and my wife was a NICU nurse before, and I look at like what we're asking our nurses to do, and it's almost, death by 1,000 paper cuts, right? Saying just do this additional task in the medical record. It just takes you 5 seconds, but if you're doing it, if you add up 5 seconds 30 times a day for, Michelle Walsh and I published an article on alarm fatigue. When we moved to our single patient unit, we had high alarms and low alarms going to the nurse badges, and they were getting 13,000 alarms a shift, which you can't, so I do think that balance is it is difficult, but it really comes down to having leadership that is involved in the day to day and trying to sort out, what are we expecting our people to do, and where are the what are the reasons that they're doing, if they're taking a shortcut, why are they doing that shortcut? And that's I don't know if that's exactly what you're looking for, but it really is, quality and safety are and there are groups like the Vermont Oxford Network and others where they really are trying to improve quality by sharing information and saying these are what we think will help, and that's just trying to explain that and take the time to have your, I don't know what's like in Australia. We do have a lot of nurse turnover nowadays. We have a lot of younger nurses who don't have the same amount of experience they used to. So you can't, your expectations have to be, you can't give a nurse on their first day a ECMO baby and go, oh, you don't know what you're doing.
Yeah.
Right.
It's a tough balance between, having indeed the new nurse and giving them what is our standards of care here versus a very experienced nurse, which actually makes an individual decision, or doctor, doesn't matter, an individual decision on a baby, which might be even better for the baby instead of the standard of care. That variation is typical, I think, of medicine. You went a little bit into the causation, the causation effect of the law and what it means. And look, a lot of your cases, there were just clear-cut errors. There is a bit of a more and more cases where it's just a gray zone, isn't it? If a 22-weeker develops an IVH, or say a 24-weeker develops an IVH, just because he was born at 24 weeks, or even if everything went perfect, what is the causation? How do we need to manage around that?
Yeah, I mean, well, I will tell you one thing. I mean, and HIE is a great example because, you have 6 hours to put the baby on a cooling blanket, and you do not have all the information. You don't have the placental pathology. You don't have all the maternal history. You don't have the MRI. You don't have the, liver function test at 24 hours. So, that's part of the reason the American Academy of Pediatrics and the American College of Obstetricians and Gynecologists have a whole monograph on, and they say, call it neonatal encephalopathy
Mm.
because the fact that a baby is depressed at birth and has bad APGARs doesn't mean it's the OB's fault because something went bad in labor. It might have been a stroke from 2 weeks ago. But how we document, I see very rarely do I see good documentation 4 days later. Looking at everything now, we think that this occurred at this time. Putting everything together, this was clearly a stroke, in utero stroke that occurred a week earlier. So the causation piece it really does have to do more documentation that we don't generally do. And it can be complex. Genetics is now a whole, a relatively new branch, but I have seen some cases where sort of bad outcome blamed on the OB, and then no, this was a genetic cause. It had nothing to do with it. But causation can be very, very, very difficult in some of these more complex cases, but that's where you do try and put together all the information that you have, including, again, that, some of the things that we can do though is say, please send that placenta to pathology, because if it's discarded, it's gone forever and you'll never, and a lot can be cord gases also. If you have an arterial and a venous cord gas, it can give you a lot of information that you won't have if they don't send them.
You highlight two things there. One, I thought was really important for us to write down a differential diagnosis, not just one of them of what we think it is, but actually write down the options and have we explored, and that the test to either include or exclude all of them might be a good start. And you highlight the fact that indeed, particularly expert opinions for the plaintiffs, they can guarantee to the hour how precise, a birth, an earlier birth could have prevented this HIV, which I find very challenging to sort of deal with that kind of sort of certainty. We have our uncertainties dealing with these cases for sure. And the last question, and we have a little bit more time. The last question was about that informed consent. I really like that. You went from informed consent to informed refusal. Could you elaborate a little bit more on that? What do we need to do?
Sure, sure. And actually, there's a very well-known case in the legal world that involved a woman. I think the case was called Truman v. Thomas, and it involved a young woman in her 30s who went to her family practitioner every year, and he would recommend a Pap smear. And every year she would refuse. She'd either say, I can't afford it, or I just don't want it. And so she wouldn't get it. And then, um, unfortunately, she developed cervical cancer and died. And her children, she had young children, and they sued and the family practice doc. And the family practice doctor lost because the court said that when a patient refuses a treatment, you then have a duty to talk to them about what that means.
Mhm.
And so the concept of informed refusal is we recommend, for that case would be we recommend a pap smear. I don't want it. Okay, do you understand that the pap smear is for, um, detecting cancer and can save your life? So, I see that a lot. I don't know in Australia, we have a lot of families that refuse vitamin K, for example.
Yeah.
And so, the concept of informed refusal would be, okay, do you understand that vitamin K is to prevent hemorrhagic, disease in the newborn, and it can lead to bleeding in the brain. That's the concept of informed refusal, not just offered vitamin K declined. It's that the family, they made an informed choice for what they were refusing.
All right, thank you. There's no questions in the chat box. I thought it was a wonderful conversation. Thank you, Nick, also for your contribution to these things, and thank you, John, for this presentation late at night. It is really part of our webinars to talk about everything in neonatology. I thought this supplemented it very, very well. Thank you so much. We are not back next week, but the week thereafter, we're back with a new webinar. John, thank you again, and thank you everybody for attending.
All right, I appreciate it. All right,
Thank you,
take
John.
care.
Bye.